Hello everyone, this is Dr. Humanist again. Let us now discuss two very important topics in hematology which look similar but there are a lot of differences. We'll see what are those key differences. Thrombotic thrombocytopenic purpura and ITP, that is immune thrombocytopenic purpura. Okay. First, coming to the pathophysiology, in TTP, because of there is a deficiency of ADAMTS13, right? What is ADAMTS13? It is a protease enzyme which will cleave the von Willebrand factor, but because of the deficiency there is a large multimers of von Willebrand factors which will lead to platelet aggregation in microvessels leading to thrombosis and microangiopathic hemolytic anemia, whereas in ITP there is autoimmune destruction of platelets by IgG antibodies which are against the surface glycoproteins proteins like GP23 and GP1b. So coming to the etiology, TTP is mostly sporadic cases, that is acquired, okay, often autoimmune triggered by infections, malignancies or pregnancy. Even congenital cases are there like Upshaw-Schulman syndrome where there is a genetic mutation in ADAMTS13 protein. Okay, whereas in TTP, primary, that is idiopathic, is most common. Secondary, which is associated with SLE, infections like HIV, H. pylori, hepatitis C, or drugs like quinine and heparin is seen, right? Clinical features, if you see now, this is the differentiating factor. In ITP, guys, only patient will be having symptoms because of thrombocytopenia, that is low platelets, predominantly bleeding manifestations like petechia, purpura, epistaxis, gingival bleeding and menorrhagia. Okay, systemic symptoms won't be there, but if you come to the TTP, there are systemic symptoms present. Why? Because thrombocytopenia, obviously it is there commonly in both the disorders, but here additionally there will be microangiopathic hemolytic anemia, as I said just now, and neurological abnormalities like stroke like symptoms will be there, like confusion, seizures, okay, altered mental status, etc. Renal dysfunction, acute kidney injury and fever. So these are the pentad of symptoms: anemia, thrombocytopenia, stroke like because of thrombotic events, and the renal dysfunction and fever. Okay, platelet count typically in TTP, as it's like crisis situation, emergency situation, the platelets might drop less than 30. In TTP, in ITP, it is variable, but usually less than 1 lakh. Hemolysis present in TTP, not in this thing, ITP. Neurological symptoms also common in TTP only. Renal involvement in TTP. Coagulation test, both cases it will be normal PT and APTT. In the TTP, as the patient is coming with crisis, we might confuse it with DIC. But in DIC, as we know, there is a derangement of PT, APTT, INR. So that's how we can rule out DIC here. Okay, if you see peripheral blood smear, we'll get schistocytes. Okay. Then bleeding symptoms, often mild. There is a more of a common thrombotic events will be common in TTP, like microthrombi, especially the small vessels are affected. Where we see the ITP, the bleeding is severe with the mucosal bleeding, menorrhagia and easy bruising. Okay. Now coming to the treatment, some treatment strategies are same, but some are different. So we'll see what is the same and what is different. So TTP, we have to first start with PLEX, that is plasma exchange. Immediately when the TTP is diagnosed, daily plasma exchange with replacement of 1.5 to 2 plasma volumes until the platelet count normalizes and hemolysis is resolved. So mortality without the PLEX is 90%, guys, and with treatment is less than 20%. Okay, next is steroids. Steroids is commonly used in both TTP as well as in ITP. In both the cases, we can use steroids. Rituximab also same, that is CD20 inhibitor, right? It is used in both the cases. Okay, even in TTP and in ITP. That is off-label use. Dose is 375 milligrams per meter square, IV weekly for 4 weeks. Okay. Next is immunosuppressive agents for refractory cases, cyclophosphamide, cyclosporine. In ITP also you can use, but not commonly used, like azathioprine, and those drugs can be used but not usually used. Okay, what are the differences? So IVIG is used mainly in the cases of ITP. Okay, the dose is 0.4 gram per kg per day for 5 days. That is total, it will become 2 gram per kg of total dose, which we give in 5 days, divided doses in 5 days. Okay, so there will be rapid response to the IVIG within 24 to 48 hours, patient's platelet counts will increase. So IVIG we do in the severe cases when the platelet counts are less than 30,000 or before surgery. Splenectomy, it is done in ITP, not in the cases of TTP. Okay, in the when there is no response to the steroids, or if there is a recurrent ITP, and splenectomy leads to long-term remission, that is 60 to 70% cases go into remission. One more drug class is thrombopoietin receptor agonist, which is used in ITP, not in cases of TTP. What are those drugs? L-trombopag, that is okay, and romiplostim. The dose of L-trombopag is 50 mg per day, can increase up to 75. Romiplostim is 1 microgram per kg subcutaneously weekly, can give up to 10 micrograms. So now platelet transfusion. Platelet transfusion can be done in ITP but not in TTP, guys. Okay, this is the key differences in treatment strategies. Don't give platelet transfusion because, as I said, there is a thrombosis, right? So if you give platelets, that will exacerbate the thrombotic events, right? But in ITP, not commonly done, but if there is a life-threatening bleeding happening, then you can go for platelet transfusion in the cases of ITP. Coming to the prognosis, in TTP, it is based on treatment. If you give treatment, 90%. Without treatment, it is 90% mortality will there. But with proper treatment like plasma exchange and immunosuppressive therapy, survival rate is more than 80%. In ITP, good prognosis with appropriate treatment. Okay, in children, it can go to spontaneous remission also. Okay, chronic ITP may require long-term therapy management like with steroids we give. Okay, relapse risk, it is high if the ADAM-TS13 levels are low even after the treatment. Ongoing immunosuppression may be required, like steroids, cyclophosphamide. It depends on the ADAM-TS13 levels, the relapse. And even in ITP, relapses are common, right? Especially after the steroid tapering, when you stop the steroids or discontinue the therapies like the TPO, that is thrombopoietin receptor agonist. Okay, so these are the key differences. One more drug I forgot to discuss, that is caplacizumab, which is used in TTP, that is anti-Willi1 factor. The dosage is 10 mg IV bolus followed by 10 mg subcutaneously daily. Okay, we have to give this alongside plasma exchange. Okay, now coming to the key difference, guys, TTP versus ITP. No, ITP is more with the concerned with the platelet count. So thrombocytopenia is what we are dealing with. So bleeding manifestations will be more in ITP. But in TTP, patient will present with like crisis, they will be present like stroke-like symptoms or renal failure or anemia, right? So it is like that. So, but ITP, when I'm saying, we are talking about isolated thrombocytopenia. But there is one more entity, that is Evans syndrome, can be like ITP only. In that, there is a hemolytic anemia, thrombocytopenia, and sometimes neutropenia also. Okay, so key differences in the treatment I discussed just now. In TTP, plasma exchange we have to do. Caplacizumab, as I said, it is anti-Willi1 factor, corticosteroids and rituximab. And in ITP, steroids, IVIG, splenectomy, and TPO receptor agonist.